Welcome, and thank you for joining us today. I am Pat Cook, Senior Consultant and Director of Administrative Services here at Kudamonch & Associates. I'm so fortunate to have with me today Christopher Pratt and Denise Smith, Associate Consultant members of our team. We are very excited to share today's program with you. We have lots of information to cover, so let's go ahead and get started. One last detail before we begin our program. Kudamonch & Associates is accredited as a provider of continuing nursing education by the American Nurses Credentialing Center Commission on Accreditation. Continuing education contact hours will be awarded upon full attendance of the program and receipt of the participant course evaluations. In order to receive CE credit hours for your participation, the electronic evaluation feedback form must be completed within 2 weeks of the educational activity. Please refer to the information included in the confirmation letter you received during registration for details in completing the post-course evaluation for CE credits. You may also inquire about credits through our website at info@kudamonchassociates.com. The planners and presenters for this session are Pat Cook, Registered Pharmacist, Denise Smith, Registered Nurse, and Christopher Pratt, Registered Nurse, all members of the consulting team here at CNA. The planners and presenters noted above have disclosed no influencing relationships or commercial support relating to this activity. Participation in an accredited activity does not imply endorsement by the provider or ANCC of any commercial products displayed in conjunction with this activity. Our objectives or learner outcomes for this program today are to ensure that everyone is able to identify one change in the survey process as a result of the COVID-19 pandemic, to be able to identify 2 current trends in survey activities, and to be able to discuss 2 2021 regulatory changes and its potential impact on organizations. Let's do a quick run through of our agenda. Today, Chris is going to spend time sharing with you some important information on the impact COVID has had on the survey process and the state of the Joint Commission and the opportunities identified during their 2020 CMS review for deemed status. We'll then hand things over to Denise, who will focus on the latest trends and problematic standards. And then to wrap up the session, I will highlight some of the areas of the new standards and the standards that we are keeping on our radar. Last but not least, we're going to field some of your questions. In order to get through the agenda, we will be placing everybody on, all the participants on mute during the program. Don't hesitate to use the chat room feature to submit your questions. So with that, let's get started. Chris, take it away.
Thanks, Pat. My name is Chris Pratt. I'm an associate consultant with Kudamonch & Associates, and I'll be presenting the next 2 sections. First of which we'll be talking about now will be the impact of COVID pandemic on the survey process. Now, as the old song goes, what a long, strange trip it's been. A year of emotion, science, heartbreak, and financial challenges. But here we are, and every day we learn to maneuver our way through the challenges of not only keeping our own daily lives moving forward, but the survey process too. The declaration of the public health emergency in March stopped the survey process as we knew it, and literally that same day, the new survey process began to evolve, and every day it continues to evolve. Now, CMS has worked closely with its deemed status accrediting organizations throughout the pandemic, keeping our eyes on the safety and quality of care delivered even during pandemic times. While I reference accrediting organizations, our focus will be on the Joint Commission as they remain the AO of choice by over 85% of hospitals. I also want to footnote that even today as we share this information, the process continues to change. So what should you expect for the remainder of the year and into 2021? Now, CMS has not fully approved a virtual triennial survey model yet, although a lot of people would love to see that. But discussions between Joint Commission and CMS continue on that subject. So if you're due, overdue, or expecting your survey in 2021, expect an on-site survey. The only CMS approved virtual survey is for initial accreditations. This became a vital component to our pandemic response. There were dozens of organizations that were either building new hospitals or building new bed capacity that needed to be surveyed so they could be open to assist with the surge capacity. For these surveys, there was a very robust communication process between the account representative and the survey coordinator at the organization. Joint Commission required the survey required documents to be uploaded to a SharePoint site, and surveyors reviewed the documents prior to conduct of the virtual review. Joint Commission is using specific monitoring criteria to determine if your location and organization is safe for their surveyors. Now, the monitoring criteria focuses on 1, the overall infection rate, and 2, the 2-week trend in the overall infection rate. The overall infection rate goal continues to change and has ranged from 1 to 3. The 2-week trend must display an improvement trajectory. Once the monitoring criteria is headed in the right direction, the account rep will contact the organization and ask a series of questions, again, continuing their assessment of your state of readiness for a survey. Based on the results of this call, your organization is either scheduled or placed on hold. If your organization is scheduled, the Joint Commission will continue to monitor the data, and the organizations have also been noted to be canceled the day before the survey start date if the trajectory is showing an increase in the COVID, or your numbers are starting to turn the way that is not going to support a safe survey. This part of the readiness journey appears to be pretty consistently applied. Moving forward from here, we are hearing a lot of variation though. This variation seems to be limited to surveyor-specific type nuances in how they survey or what type of content that they actually want to look at. On day 1, there should be some type of communication with your team leader. Most organizations report receiving a call from the team leader that morning to verify the COVID-19 screening process of your organization. The Joint Commission will not survey organizations that are routinely requiring the use of N95 respirators at this point. Surveyors will follow your requirements, so be prepared to provide your surveyors with masks and any other PPE required by your organizations. Surveyors will begin surveying your compliance with the CDC guidelines from the moment they pull in the driveway. As they enter the building, they'll begin to observe for proper PPE use. So, how many noses do you see sticking out of your masks? Are staff wearing disposable gloves? Are they wearing disposable gowns? Are they working behind plexiglass, or are they working around the plexiglass? Who do you have doing your screening process, and are they performing it accurately and consistently? They will be looking. Be ready for that. So here's where we're hearing a lot of the variability, and are certain much of the variability depends on individual circumstances. Joint Commission advises that surveyors are not to observe aerosol generating procedures unless they can be observed through a window or some type of observatory. So depending on the physical design of your care locations, the surveyors may observe or they may not. Joint Commission also advises that surveyors will not visit care locations with known COVID-19 patients. So you need to be prepared that you have an accurate listing of these patients and what units they're on. We're also hearing that surveyors are conducting shortened unit visits and focus on the physical clinical environment, observation of staff, and interview of staff. Most organizations report that chart review is being conducted remotely, and this is for open and closed record reviews. We're also hearing from many organizations that surveyors are conducting combined interview sessions. Most common is the combination of infection control, medication management, and data management into one session. So you should make certain that you can muster the people required for those sessions and have them ready to go in case they want to start combining those sessions. We're also hearing that some surveyors are asking for presentations or displays of data and information. We believe this is a byproduct of trying to facilitate an interview session that supports social distancing and virtual participation, and is a tool to keep the participants on target or engaged in the discussion. So let's talk about tips for success. Socially distanced virtual participation interview sessions are a challenge. We can continue to get better and better at it, but there's some tips that you should take note of to make certain your sessions are successful. Number one, don't hesitate to have an IT support person in the room to either problem solve or to moderate the technology aspect of the interview session. Number two, encourage participants to call in from a landline. Cell service can be sketchy at times, and they can create a real barrier to the process of virtual interviews. Third, make certain participants understand how to use the virtual platform, how to mute, how to unmute, how not to use the computer audio if you're calling in, because that can create some feedback that can disrupt the session. Next, establish some virtual etiquette rules. Now, will you require all participants to be virtually displayed? If yes, what rules come along with that, such as clothing, attire, background, things like that? Make certain that they pay attention. Make certain they don't multitask. So no answering email while you're sitting in these virtual sessions. Do not walk away from your virtual session site to go down the hallway to get something to drink. Don't answer the phone. Better yet, make certain you've answered the phone. You've got your phone muted, excuse me. Do not answer other people that come to your office. Make certain you put something on your door that says that you're not to be disturbed for that session. Next, assign key topics to key personnel. Virtual participation can be difficult and unruly sometimes. Having a plan for who will lead, who will follow is very helpful. And it's always good to practice that. Provide your surveyors with a list of participants and what their role is. And we probably all experience that the voice is the only associated with a telephone number aspect. So if you've ever participated in a Zoom meeting, for example, you'll see the phone number listed and you'll hear a voice, but you really can't put into context who this person is. So you want to make certain you support your survey team. Do they understand who's who in the zoo, as they say? Some additional survey process tips. Virtual record review can be a challenge sometimes as well. Consider dual screens so that your electronic medical record expert can drive the record from at least 6 feet away and the surveyor can view the record while maintaining that social distance. And I would highly recommend you practice that. We've done our own surveys with our clients and we've seen that that setup tends to be the best way to ensure a good virtual record review. Remember also that your survey team may need to be able to socially distance while in their office space that you provide for them. Expect that they may actually spend more time in their survey office space than they would necessarily out and about pre-COVID. Some additional survey process tips. Virtual record review can be a challenge sometimes as well. Consider dual screens so that your electronic medical record expert can drive the record from at least 6 feet away and the surveyor can view the record while maintaining that social distance. And I would highly recommend you practice that. We've done our own surveys with our clients and we've seen that that setup tends to be the best way to ensure a good virtual record review. Remember also that your survey team may need to be able to socially distance while in their office space that you provide for them. Expect that they may actually spend more time in their survey office space than they would necessarily out and about pre-COVID. Now, during the initial shutdown period, the Joint Commission put together a team of physician surveyors to review and establish a uniform and consistent process to guide the medical staff survey process. As a result of the 2021 Survey Activity Guide will contain several new checklists designed to assist you in preparation. These include an updated bylaws checklist and a credentialing file review checklist. So you're going to want to get those so you can use those as you do your practice virtual sessions. As a reminder, we've heard from recent surveys that surveyors are looking for evidence of the approval by the organized medical staff of the diet manual, radiology, and nuclear medical staff qualifications, along with documentation of medical staff education related to antibiotic stewardship. So you want to make certain that your records contain those as well. Our next section, we're going to talk about some of the content from the recent CMS survey of the Joint Commission during their requalification period. So this section, we're going to talk about the State of Joint Commission, specifically as a result from the CMS's review of their regulatory agency and some of the changes that they're expecting to see from Joint Commission. As many of you are aware, every accrediting organization that has achieved deemed status ranking with CMS must undergo an evaluation to ensure that they're following the standards as put out by CMS. We equate this evaluation to the clinical contracting and performance evaluation standards that exist within each of the Joint Commission accreditation programs. And as they say, what goes around comes around. The deemed status evaluation process is very robust, and it considers the following items. First would be internal policies and procedures related to Joint Commission operations. This includes their financial resources and also their human resources. In regards to their human resources, specific focus is on the process for training, evaluating, monitoring the performance of the surveyors. Joint Commission has put forth a significant effort in the past 5 years or so to establish consistent application of the standards and the elements of performance, and establish the consistent interpretation series that appears in perspectives each month to help us understand their interpretations. At the heart of every regulatory agency is the complaint process, often viewed as the unbiased review of quality and safety. The evaluation process considers how complaints are investigated. Next, there's observation. Representatives from CMS conduct an on-site visit to Joint Commission headquarters in addition to considering the result of each validation survey. And last but not least, there's an intense review of the standard and validation alignment of the standards with the conditions of participation. CMS conducted its most recent evaluation and review of Joint Commission this past spring. The results appear in the July 17th issue of the Federal Register. So, how do you think they did? Now, there were about 14 opportunities for improvement identified by the CMS review. Some were very low, easy fixes. For instance, several opportunities where the Joint Commission needed to align their terminology to the conditions of participation terminology, revisions to the accreditation award letter, and updating of references. But there are 4 areas on this slide that will have an impact on future surveys. For all provider-based locations, CMS is pushing that for every care location that's part of your CCN number to be surveyed for compliance with EC and life safety requirements. CMS recognizes to do this that additional training of surveyors will be required. Joint Commission recognizes, along with CMS, in order to survey more care locations, the composition and the number of surveyors or survey days will need to increase. And based upon observations, CMS felt that surveyors provided leading questions and not necessarily probing questions. So instead of asking, you do assess for pain, don't you? Yes or no answer. They should be asking, tell me how you assess for pain. CMS went on to describe additional opportunities found during their review process of Joint Commission. Staff should be interviewed in private to avoid any barriers to transparency, so they really are recommending that supervisors and leadership is not present during those staff interviews. They also wanted to note that the level of detail provided at the daily briefings should be shortened to sharing of only high-level information and not in the detail that is often found during observations. Medical records need to be reviewed in greater detail, so do expect to see more scrutiny placed on your medical records. Joint Commission should also consider expanding citations within the governing body to include EC and life safety findings, and this is aligned with their increased focus on leadership accountability. They also noted with credentialing and HR file reviews that surveyor training in the review process is really necessary and needs to be bolstered up. Additionally, implementation of a unique identifier means of tracking opportunities such as medical record number 1, medical record number 2, staff member number 6, staff member number 8, as a way to help the organization track where there's some opportunities, where they're starting seeing some trends. So that'll help the organization in terms of looking at their findings to be able to identify those opportunities and work on them more effectively. So in the summary of the CMS review of the Joint Commission back in the spring, their summary contained these two statements. First is, quote, concerns about the thoroughness of review conducted within the facility, unquote, and, quote, concerns related to the comparability of the Joint Commission survey process to the CMS survey process, end quote. Some pretty significant comments made to their concerns regarding how Joint Commission is performing as an accrediting organization. In the end, Joint Commission was awarded a 2-year renewal to their deeming status, and the maximum award available is 6 years. CMS has stated numerous times through Seema Verma, who's their director, that they intend to provide closer oversight to all accrediting organizations. And we believe Joint Commission was the first to really feel the effects of this new level of oversight. So what does this all really mean to healthcare organizations? Potential changes to the daily briefing process. Perhaps the briefing occurs at the 30,000-foot view, so you're not going to get as much level of detail that you're used to during the Joint Commission survey. So that's going to really put a lot of responsibility on your staff when they start seeing some trending and providing your command center with a little bit more detail in the observations of the survey teams. We'll expect to see changes to the staff interview process and aligns with the social distancing requirements. We see some changes in terms of enhanced medical record review process, aligning with the same social distance requirements envisioned for a virtual survey. Don't forget that the CMS has an ATAG medical record review form that was released in 2019, and that's a very good guide to get in terms of looking at your own medical records in that level of detail. We do expect to see a larger or even a longer survey. We're not aware that Joint Commission and CMS are seeing eye to eye on the number of off-site locations that must be surveyed. This all really goes back to, we expect to see further intensification of oversight by CMS. So with Joint Commission having their initial renewal for 2 years, in 2 years, for probably now about a year and a half, we might even see more oversight and more scrutiny by CMS on their survey process. So thank you very much for your attendance with my section. Our next section on Joint Commission trends with observations and problematic findings will be presented by my colleague, Denise Smith. So take it away, Denise.
Thanks, Chris. Now let's talk about what is going on out in the field, the latest trends and problematic standards. The Joint Commission adopted a formal sentinel event policy in 1996 to help hospitals that experience serious adverse events to protect the patient, improve processes and systems, and prevent further harm. This slide, published by the Joint Commission in April of 2020, shows those events by category that were reviewed by the Joint Commission in 2019. There were a total of 844 sentinel events, 83% of which were self-reported. Please note that the categories of events were consistent with recent years. Now let's break down these categories and see what they include. For case management, there were falls, delay in treatment, and medication management issues. For surgical and invasive procedures, unintended retention of a foreign object in a patient after an invasive procedure, including surgery, a procedure performed at the wrong site, on the wrong patient, or that is the wrong or unintended procedure for a patient, and operative and postoperative complications. In the suicide category, suicide of any patient receiving care, treatment, and services in a staffed around-the-clock care setting or within 72 hours of discharge, including from the hospital's emergency room. For the protection events category, this includes self-harm, assault, and infant abduction. For the environmental category, this includes fire, medical equipment, and medical surgical supplies. And finally, in the product or device category, medication equipment and medical surgical supplies are included. On a regular basis, the Joint Commission aggregates standards compliance data to identify areas that result in the highest number of requirements for improvement in accredited and certified programs. This data helps the Joint Commission recognize trends and tailor education around challenging standards and the national patient safety goals. The 2019 most frequently scored patterns for hospitals included the following categories: infection control, environment of care, national patient safety goals, medication management, leadership, and provision of care. For infection control, the citations were related to immediate and high-level disinfection and sterilization, that it was performed properly and followed the manufacturer's IFU, that there was processes in place for cleaning equipment, specifically at the point of use, minimizing risk, infection control surveillance to minimize and reduce and eliminate the risk of infection. There were citations for improper documentation, no evidence of cleaning, ultrasound probe issues, as well as safe storage of medical devices and supplies. Here are some examples of what surveyors have been finding. In the upper left, you see corrosion on a surgical instrument, rust. Lower left, the use of tape on a probe connection, which is a possible electrical hazard. The middle picture shows a clean ventilator bagged adjacent to a contaminated ventilator, adjacent to a decontamination sink. And finally, on the right, tissue on a drill bit, not having any enzymatic spray or means to keep the instrument moist. The Joint Commission continues to find deficiencies in the environment of care area. Safe environment and interior spaces with blocked egress, as well as sharps containers being filled, for example. The sterile compounding area not in compliance with USP 797. They have found dirty ceiling tiles, porous surfaces, utility systems issues, temperature and humidity readings missing or not reported, ventilation system filters not changed, appropriate pressure relationships in the patient care areas not in compliance, control of airborne contaminants, and risk assessments with humidity waivers. Here are some examples of environment of care deficiencies that are frequently found. In the upper left, you have a hallway with equipment on both sides blocking an egress. The lower left picture shows a sharps container that is overflowing on the floor and not secured. The middle picture is a blocked electrical shutoff. And finally, on the right, cardboard boxes on the floor, and those cardboard boxes have shipping labels on them. As you saw from the grid earlier, National Patient Safety Goal 15 ranks third highest in those standards that have been found to be non-compliant. National Patient Safety Goal 15 has to do with the reduction of the risk for suicide. For psychiatric hospitals and psychiatric units in general hospitals, hospitals need to conduct environmental risk assessments that identify features in the physical environment that could be used to attempt suicide. Hospitals should take necessary action to minimize the risks. For example, remove anchor points, door hinges, and hooks that can be used for hanging. For non-psychiatric units in general hospitals, the organization needs to implement procedures to mitigate the risk of suicide for patients at high risk for suicide, such as one-on-one monitoring, moving objects that pose a risk for self-harm if they can be removed without adversely affecting the patient's medical care, assessing objects brought into the room by visitors, and using safe transportation procedures when moving patients to other parts of the hospital. Screening of all patients for suicidal ideations who are being evaluated or treated for behavioral health conditions as their primary reason for care using a valid screening tool. Here are some examples. On the left, you have a ligature risk from dislodged hardware on a door. In the middle picture, you have a radiator with damage and sharp edges in a behavioral health unit bathroom. And on the right, an access panel with a gap that is a ligature risk. Now let's talk about medication management. The frequently scored standard is related to safely administering medications. Before administration, the individual administering the medication should do the following. Verifies that the medication selected matches the medication order and product label. Visually inspects the medication for particulates, discoloration, and other loss of integrity. Verifies that the medication has not expired. Verifies that no contraindications exist. Verifies that the medication is being administered at the proper time, in the proper prescribed dose, and by the correct route. Discusses any unresolved concerns about the medication with the patient's licensed independent practitioner, prescriber, if different from the licensed independent practitioner, and/or staff involved with the patient's care, treatment, and services. Here are some examples of medication management issues. On the left, we have an overflowing chemo waste container, which is not covered and not secured, not in a stand, which then becomes a tip hazard. On the right, we have unlabeled syringes and labels with no information on them. Syringes with medication in them are frequently found discarded in sharps containers. It is important to remind staff and physicians, in particular anesthesiologists, to dispose of all medication in the syringe properly and then place the syringe in the sharps container. Now let's talk about leadership. The governing body is ultimately accountable for the safety and quality of care, treatment, and services within the hospital. The hospital has a governing body that assumes full legal responsibility for the operations of the hospital. The board carries out oversight responsibility across the organization in areas such as business and risk strategy, organization, financial soundness, and regulatory compliance. The governing board is responsible for ensuring that the staff has the support and resources necessary to enable them to fulfill their roles. The board is also responsible for reviewing the quality of medical care delivered in the hospital through the Quality Assurance Program. The governing board, along with leadership, are ultimately responsible for the safety and quality of care, treatment, and services provided to the patients in the organization. Now let's talk about provision of care. The deficiency frequently cited is that the hospital stores food and nutrition products, including those brought in by the patient or their families, using proper sanitation, temperature, light, moisture, ventilation, and security. Food should be stored in appropriate containers in refrigerators designated for patients. Labels should be legible. Non-food items should be stored in another refrigerator or area. Only patient food should be in the designated food refrigerator. Food storage areas such as counters, closets, shelves, refrigerator, freezers need to be cleaned when dirty and if spills occur. Refrigerator temperatures should be logged, and if the temperature is out of range, engineering should be called for remediation and a follow-up temperature documented. Labeling and expiration dates should be on all food products, and expired food should be discarded promptly. Now here are some examples of food storage issues. On the left, we have food and biohazard materials intermixed in the same refrigerator. Biohazard bags should be only used for biohazard materials, and biohazard materials should not be stored in the patient refrigerator. In the center, we have mold on styrofoam in a refrigerator. And finally, breast milk labeling inconsistencies. If you look at them, one has a barcode sticker on it and the other has a label with illegible writing.
Great job, Chris and Denise. Now that you have learned about the survey process, state of Joint Commission, and the problematic standards, let's spend some time talking about what we are keeping on our radar for 2021, including those new standards. There are some minor revisions coming in January to the emergency management standards for ambulatory behavioral nursing care centers, laboratory, and office-based surgery accreditation programs. While initially this would have been very helpful, the pandemic arrived. Healthcare organizations activated their emergency operations plan, and into disaster mode we went. Not only did we deal with COVID, but wildfires, hurricanes, and civil unrest may have also resulted in activation of your emergency operations plan. What this standard was designed to do was to allow organizations accredited by those programs that I mentioned to conduct a full-scale community-based or facility-based, functional-based test of their system every other year. And on the opposite years, the organizations would be permitted to either conduct a full-scale community or facility exercise or utilize a mock disaster drill or tabletop exercise or workshop in those alternate years. However, we also have learned that Joint Commission will be rewriting the emergency management standards, and they will be a complete rewrite that will be released most likely in 2022. Additionally, we understand that Joint Commission will be in 2021 expanding the review time for emergency management from the usually scheduled 60 minutes to 90 minutes, and that cybersecurity will still remain a significant issue for discussion during this survey activity. Continuing with emergency management, keep on your radar the expiration of the public health emergency. Hopefully in early to mid 2021, this will occur. And remember that when it expires, the categorical 1135 waivers will also expire. Keep in mind that in order to qualify for using any of the 1135 waivers, your emergency operations plan must be activated. Once you deactivate your emergency operations plan, your ability to take advantage of those waivers expires. On our environment of care radar, we have the EC Life Safety Document Review Session. We understand from Joint Commission that in 2021, the document review session will be expanded to 200 minutes. This allows almost 3.5 hours of document review dedicated exclusively to the environment of care and life safety. We're also monitoring and keeping track of the waterborne pathogens standards, which we'll talk about in just a few minutes. Keep in mind that earlier this year, Joint Commission announced that CMS is requiring them to survey more of your off-site ambulatory locations. Don't expect that the EC Life Safety Surveyor will necessarily conduct these reviews, as Joint Commission has been training their clinical surveyors to be able to assess and evaluate those ambulatory locations from an EC Life Safety perspective. And then last but not least, still on our radar in the environment of care is workplace violence. This has been an initiative that Joint Commission undertook several years ago. They've partnered with several key stakeholder organizations, and we anticipate that there will be a entire set of standards dedicated to reducing and eliminating workplace violence. As you may remember, Joint Commission took on workplace violence about 2 years ago. Through the establishment of a multidisciplinary team, they explored, investigated, and sought deeper understanding to facilitate the development of standards to focus organizations on this current valid concern. We're hearing that there are about 20 standards, new and revised, that will address workplace violence, and those standards will be woven throughout almost every Joint Commission chapter. We're providing you the link to the story of Captain Katie Blanchard and her amazing story. This video is about 7.5 minutes long in length. Katie actually served on the Joint Commission Task Force to develop these new standards and create new motivation to work on reducing workplace violence. I am certain that when you listen to her story, it will trigger many memories of similar behaviors you may have encountered in your careers. Delayed from an effective date of July 1st, 2020, the perinatal safety standards take effect January 1st, 2021. There are 2 new standards with 13 elements of performance. The next several slides summarize these requirements. At the core of these requirements, there is a fair amount of the components that will require documentation, such as your protocol, algorithm, education provided to both staff, LIPs, and patients, along with the entire data collection, analysis, trending, and reporting of measures. We consider this low-hanging fruit for surveyors that are either on site with you or conducting a virtual review, should a virtual survey process be approved. At the very core of these standards, I see some of the principles of high reliability, along with some of the lessons learned from Sentinel events. For instance, ensuring access and dependence upon expert resources and simulation to ensure we remain nimble and adaptable come from the principles of high reliability, while establishing a commitment and process to ensure that the patient and family are kept well informed of what is happening and expectations, coupled with looking for opportunities post-management of these patients, is often a key factor learned from Sentinel events. You will see that both the severe hypertension, preeclampsia, and maternal hemorrhage standards follow the same framework. Evidence-based best practices, preparedness, resources, communication, and training competencies. The role-specific education is an area that we think organizations need to focus on hardwiring into their organization. Be certain to define in your protocol when your annual drills will occur, who will be held responsible for facilitating those drills, working with your electronic medical record vendor to build the content and record documentation components is essential. And don't forget to incorporate the role-specific education into both your new hire orientation and your orientation process for anyone who transfers between departments. Two additional standards that we want to draw your attention to that will take effect January 1st, 2021 are the following. Joint Commission will be updating their Sentinel event policy to include a definition of fall events. This is being done to help staff in all healthcare settings to be able to understand whether a fall should be reviewed as a Sentinel event. The second standard appears at HR 010101 EP1 of the Hospital Accreditation Program or the Hospital Manual. This standard applies to any hospital that uses Joint Commission accreditation for deemed status purposes and requires the organization to designate in writing the staff qualified to perform specific respiratory care procedures and the amount of supervision required to carry out each of those specific procedures. This must appear within an organization policy. Disparities in healthcare remain on our radar as the disparities that exist in healthcare have become more and more evident as we move through the COVID-19 pandemic. Joint Commission began this endeavor, I'm going to say about 2 years ago. They understand the complexity and the enormous undertaking that this will take. They will not be the only stakeholders in the group that's looking at and working on disparities in healthcare. And we expect that in either late 2021 or early 2022, we may begin to get our first look at what their thoughts are around designing standards and elements of performance that will help us address disparities in healthcare. The second area that remains on our radar is the data management and leadership chapters. As you are probably aware, the emphasis in both of these chapters needs to focus us even more on how we look at data and what organizations are doing with that data. So how do we look at data? Are we using display graphs? Are we looking and tracking performance over time? And then secondly, when we identify opportunities for improvement or for performance that's not meeting our expectations, what do we do with that data? How do we design improvement work that is meaningful? There are two medication-related standards that we continue to keep our eyes on. The first one is related to medication titration orders. Joint Commission revised that standard and the revision takes effect January 1st of 2021. The standard gives a deeper understanding and a deeper definition in terms of what needs to be in the medication order in order for it to meet all of the requirements for a medication titration order. So the January 2021 standard requires you to have the name, dose, route, frequency, initial rate of infusion, and most importantly, the last few parameters. Incremental units to increase or decrease by, frequency by which you can increase or decrease that rate, a maximum dose or maximum rate for that infusion, And then last but not least, the clinical parameter to be measured to guide the changes. Are you monitoring to a blood pressure, to a heart rate, to a RAS score, to a pain score? There's lots of different parameters that can be used, but this is a major focus. Joint Commission also introduced in September a new element of performance within the medication management standards. This element of performance allows organizations to establish a well-defined internal policy outlining its specific parameters for when block charting is permissible. We encourage organizations to consider the risk versus benefit prior to pursuing block charting. Last but not least, in September 2020, the Joint Commission also pushed out their proposed standard changes related to water management. These standards are designed to cast a broader net around how we as organizations monitor, manage, and respond to concerns related to water. Elements of performance within these standards will require a written water risk management plan, a diagram of the water flow throughout the organization, and designation of an individual or team that will be responsible for oversight and implementation of the water management plan and the monitoring parameters. There will also be a requirement for a proactive strategy to managing areas with reduced water usage or no water usage to prevent stagnation. We anticipate that the standards will be finalized in early 2021 and will most likely take effect in July of 2021. In closing, we want to thank you for your ongoing commitment to providing the best care possible to your patients, for caring for your coworkers, neighbors, and communities, especially during these difficult times. The team at CNA is here, ready to lend guidance, support, and extra hands to you and your teams. Contact us to learn about some of the new virtual services we can offer or to explore mock survey services. Wishing you all a wonderful holiday season, and here's to a fantastic new year. At this time, I'd like to turn it over to Rhonda Katzman, our Chief Operating Officer here at Kudamanch & Associates. Rhonda has been monitoring the chat room, and she's going to share with you some of the questions that have come about. Rhonda, it's all yours.